So, good morning, everyone.
Good morning, ma'am.
Happy New Year. Happy New Year, Brajesh.
Happy New Year, ma'am.
Everyone, Happy New Year.
Happy New Year, ma'am.
Thank you, ma'am. Thank you.
Okay, good. So, now we are starting the first lecture of the new year. And this is an important lecture. I want to say that, and Dr. Brajesh has prepared it really well. And we all should know about NDPS Act. What was its past, what is present, and what exactly we should do, and what are our responsibilities towards this NDPS Act. So Brajesh is our department assistant professor. He is a recipient of various awards and prizes in the various conferences. He actively participates in all the work at department, and he has really worked hard in the implementation of end of life care policy aims. Basically, when we were drafting this policy, I think he has really worked hard with the team, and he has also worked hard to develop NDPS Act implementation, means like opioid procurement, record keeping, dispensing at not only at IRCH AIMS but also National Cancer Institute Chhachar. And he is also instrumental in development of making our own online software where with the single number that is called unique identification number of a patient, we can track that patient in between our both the centers and in all whole of AIMS, that about the status of morphine procurement or morphine and any other opioid procurement with that software, which we are planning to expand in various other hospitals of the country. So with this, I think I request Brajesh to start his lecture. Is going to be very, very useful, I'm sure. And whosoever has any question at the end, kindly write down your questions in the chat box. We will take it one by one. Brajesh, go ahead, please.
Thank you, ma'am, for your kind words. First of all, a very happy new year to all of you. I'm presenting my seminar on briefly about the NDPS Act, its past, present, and future. About the brief history of opioids regulation in British era, there are three main acts that were there for the control of opioids. These are Opium Act 1857, Opium Act 1878, and the Dangerous Drug Act 1930. And the same act was implemented after independence. And in 1950, the Opium and Revenue Law Act has been formed. And in this act, all other acts has been incorporated, like Opium Act 1857, Opium Act 1878, Revenue Recovery Act 1890, the Government Trading Taxation Act 1926, Dangerous Drug Act 1930, Taxation on Income 1947, and the Payment of Taxes 1949. But still, there are many lacunas, and the government required a new act for the control of all drugs. And why there is need to develop a new act of NDPS? The lacunas are like the penalties under the previous act was not sufficient. The country is facing problem of trafficking of drugs from neighbor countries. The law does not provide enough power to officers of central agencies for investigations of offenses. Variety of international law has been evolved through international treaties and conventions. There are no law to exercise for control over psychotropic substance in India. So after all these lacunas, the NDPS Act has been formed in 1985, and under umbrella control of NDPS Act, from cultivations to extraction of alkaloids and manufacturing of pharmaceutical agents has been done. And the Central for Control is situated at Gwalior under the name of Central Bureau of Narcotics, which gives the licensing for cultivation of opioids in only few districts of MP, UP, and Rajasthan. And this all cultivation has been under supervision of officers of Central Bureau of Narcotics. And after cultivation, the entire opium has been tendered and transferred to government opium and alkaloid works. There are only two. One is situated at Gazipur and another was situated at Neemaj. And here the dry opium has been extracted from opium in opium factory, and again this dry opium has been converted, and the alkaloids has been extracted from alkaloid plants. This alkaloids has been used for the production of different opioids for pharmaceutical use. About NDPS Act, this act is after implementation of this act, it will be extended to the whole India and applied to the all citizen of India and all person who are on ship or aircraft which are registered in India, but wherever they may be. It includes also all international conventions like New York 1961, Vienna 1971, Geneva 1972. And after this act, multiple new definitions has been come, and different authorities which are involved for the procurement of medicinal use of opioids are. I'm briefly discussing about the procurement and stocking of opioids before 2014 amendment. And for the procurement, approved practitioner has to apply to collector for licensing in Form 3D DD5, and drug controller and assistant drug controller are also involved for licensing of other drugs other than morphine or pethidine. And director of health services are also involved if procurement is done for the medical institute, for any mission or corporate bodies, or any other railway hospital or any other hospitals. Excise department was also incorporated in this rule for monitoring of use of opioids and for export of opioids. And there is also involvement of transport department for transport of opioids from one state to another state. And this process is very complicated, and it's almost similar like transport of transport of any drug from one country to another country. What happened after this NDPS has been implemented in 1985? Until the early 1980s, the increase in morphine consumption in India was consistent and increased as per rest of world. After the NDPS Act, a sudden and significant reduction in opioid consumption has been seen, and it's because of a very complex set of procurement regulation, which discourages for pharmacists and hospitals to stock the opioids and healthcare workers for prescribing it. And the consumption of morphine is almost dropped by 97%, and it's reached just around 18 kg in 1997. In 2008, the amount of morphine which were consumed is sufficient to treat only 4% of patients who are suffering from moderate to severe pain. And after all this, I would like to discuss the few articles which are important for the major changes in NDPS Act. This is a research article published in 2013 in Annals of Oncology. This is a survey report known as Global Opioid Policy Initiative. And this survey report presents the report of regulation and barriers for the use of opioids in India. And they concluded that opioid availability continued to be critically low throughout the most of India, and there is urgent need for the process to bring about improved access to opioids and other essential drugs. And they also found that there are two major policy factors that contribute for the decreased use and decreased procurement of morphine. The first one is the 10 years imprisonment for any violation involving NDPS Act. And this leads to pharmacists dropping morphine stocks. And the second one is the state, which all state adopted a complex narcotic drugs rule after the NDPS Act 1985, and which required licensing to transport morphine from one state to another state. They For any transport, the authorities has to have a import license, they have to export license, and they have to take transport license. All this license, getting all this license is very cumbersome, and it's almost like shipment between the countries. This is another article published in 2014, and the objective of this article was to examine the barriers of opioid availability and cancer pain management in India. And they also found that morphine is more available at the study site only, and it's not available most part of India. And access is limited to patients seen by the palliative care services, and there is significant gap in supply of opioids. And system to measure and improve pain outcome are largely absent. The key barrier that are related to pain management includes role of nursing, opioid misperception, bureaucratic hurdles, and socio-cultural infrastructure changes. This article concluded that macro and micro level policies and practice changes are required to improve opioid availability and cancer pain management in India. After all this, there are efforts has been taken by the different bodies to ease the availability of morphine. In 2017, a public interest litigation has been filed by Indian Association of Palliative Care for pleading for access for morphine to patient in pain. And in 2013, efforts are underway to bring about federal control of opioids law and major revision in the NDPS Act. And this bill has been incorporated for following changes. And these are ensuring that a patient using narcotic drugs or psychotropic substance as medicine is not considered a substance abuser, enabling the central government to ensure proactive the availability of narcotic drugs and psychotropic substance for medical and scientific use, transfer to the federal from the state government, simplifying the process of licensing for import, export, and transport of opioids. Then multiple amendments has been done. Out of this, the important amendment is the 2014 amendment. I'm discussing about the details of this 2014 amendment. Why this amendment has been occurred? There is one rule in section 31A in which the section 31A has says that any repeat offenses is obligate for a death punishment. And in 2014, Mumbai High Court has give decision under Indian Harm Reduction Network that this sentence is unconstitutional and this should be changed. And after Mumbai High Court's decision, the sentence has been changed from shall be punishable by death to shall be punished with punishment specific in section 31 or with death. And then also multiple changes has been done for the procurement and stocking of opioids. Why this 2014 amendment is very important? Because in this amendment, they are mainly concentrating on the patient and benefits of opioids. Patient with severe pain not able to get opioids because state rules are very difficult. So this has been changed, and other stocking, import, and transport all are very difficult for getting license and transport. So all these steps has been changed. And the basic for this amendment are that after this amendment, the opioid has been found to be a safe, economical, and effective for management of severe pain in selected group of patients. There is need to facilitate and improve access to opioids for medical use while maintaining, strengthening, and integrating program to control misuse and diversion. And a uniform, simple procedures are required to procurement for opioids for medical use across the country. Glimpse of 2014 amendment. There is the regulation are applicable uniformly across the India, and it's expanded the scope of Act to include medical and scientific use, and it's defined recognized medical institute with criteria for stocking and dispensing opioids for medical use, and confirmed the power of authorization from different state bodies to single state drug controller or drug commissioner. And its amendment, this amendment has give a specific list of drugs which are included, and all these drugs are named as essential narcotic drugs. These are morphine, methadone, codeine, hydrocodone, oxycodone, and fentanyl. And in 2018, tramadol has also been added in this list. Now coming to the important terminology that was given in NDPS Act. The medical institute is all medical institute who are dealing with patient, giving treatment to the patient. And recognized medical institute are the medical institute who have the facility to control the, recognized medical institute is the institute who are dealing with the patient with severe pain and patient who required opioids for their management, and the institute which have the purchase, processing, and dispensing of essential narcotic drugs. The officer in charge of RMI, any person who are registered with the Medical Council of India or Dental Council of India has become officer in charge of RMI after getting some training for the use of essential narcotic drugs. Essential narcotic drugs, this list of drugs I have already been discussed. And for any medical institute who want to become a recognized medical institute requires some prerequisites. These are: the institute must have an officer in charge of essential narcotic drugs. The institute must have an officer, the officer in charge must have qualified doctor with registered with MCI or DCI and some training. The institute must have the facility for safe storage of essential narcotic drugs. As per rule, institute must have a double locking system. The institute has the basic infrastructure facility for staff and must have evaluating and managing for the patient. The facility should provide proof of space and person for the record keeping of essential narcotics drugs, and the institute should have capacity to maintain a register of consumption of opioids on daily basis. And now coming to the responsibilities of recognized medical institute. Recognized medical institutes shall ensure and maintain a minimum mandatory requirement as per rule, and hospital must submit the annual consumption report. They have to submit their consumption report at the end of the year, and all drugs should be prescribed by registered medical practitioner, and every recognized medical institute shall designate one or more registered medical practitioner who shall be using essential narcotics. And when there are more than one registered medical practitioner in any institute who are prescribing opioids, then there should be an overall officer in charge. The institute shall ensure that all registered medical practitioners have completed their certificate training. The drugs should be procured from the authorized chemist or dealer. All essential narcotic drugs shall be prescribed as per rule, and record keeping should be done as per rule. All essential narcotic drugs which are procured by the institute should not be transferred or loaned to any other institute. except after getting written permission from drug controller of that state. All records and registers shall be maintained and kept for at least 2 years from the last entry. And the expired stock of essential narcotic drugs shall be destroyed in the presence of officer designated by state drug controller or commissioner. And the unused essential narcotic drugs returned by the patient or their relatives shall be considered as recipient, and it should be added into the account. Or RMI shall submit the annual return before 31st March every year, and they have even if they did not use any drugs, they have to submit their annual return. Now coming to the responsibilities of medical officer in charge of recognized medical institute. All medical officer in charge ensure that essential narcotics drugs shall be dispensed to the selected patients who are registered with the RMI, and they ensure that RMI uses ENDs in illicit manner, specific as per the rule. They ensure that prescriptions are made rationally on valid clinical ground, and they ensure that the stock of ENDs in the RMI are uninterrupted and adequately available for medical use for their patients. And it should be estimates should be sent timely before to the state drug controller in time. Ensure that all essential narcotic drugs are kept under safe custody to prevent possible misuse and diversion. Records should be maintained in Form 3H, and patient-related records should be maintained in Form 3E. All forms shall be preserved for the 2 years from last entry. Officer in charge shall authorize the or deputy qualified person to carry such quantity of essential narcotics drugs for the home-based care of patient, and they maintain the record of issue and receipt of essential narcotic drugs used for such home-based care. And in the end of the calendar year, the medical officer in charge should submit the consumption in Form 3I to controller of drugs, and ensure that the expired stock should be destroyed in the presence of representative of state drug controller. And in the event of any changes in constitution of RMI, suppose they have enrolled other of medical officer for dispensing, prescribing of opioids, then all this should be informed to the state drug controller within 30 days after the changes in the institute. Now coming to the steps for the procurement of ENDs for any medical institute. First of all, medical institute has to apply to state drug controller or commissioner with Form 3F. And then state drug controller, and for any private practitioner who wants to stock opioids, they have also have to apply in Form 3F, and then they got a list of maximum quantity of essential narcotic drugs. This maximum quantity of ENDs is very low, so for private practitioner, they again apply in Form 3B for procurement of a number of opioids, and this form has mentioned how much quantity they want to procure. Then the private practitioner has to maintain their records in Form 3D on daily basis. And for institute, after applying in Form 3F, the state drug controller issues Form 3G. Then this is a certificate of recognition, and along with certificate of recognition, the order purchase copy has been issued by state drug controller. Both this Form 3G and order of purchase should send to the licensed distributor of opiates. The list can get from the state drug controller, and from licensed distributor, the required amount of opioids has sent to the institute along with Form 3C. This is 3C is a consignment note, In this, the details of transport has mentioned and the number of medicine quantity and even the timing of dispense of vehicle, the number plate details of that vehicle has mentioned in this form. And after getting medications at the institute level, we have to check the consignment is all medications are appropriate and adequate. Then all medication has been stored at a designated area with double lock facility and designated pharmacist for record keeping of all essential narcotic drugs. This record keeping is done on 3H form on daily basis, and then the opioids has been dispensed to patient, or it can be dispensed from ward to the patient. And whenever we dispense opioids to patient, we have to fill Form 3E, and all these forms kept for at least 2 years from last entry. Then at the end of the year, the all consumption has been entered into Form 3I, and the next year's requirement has been entered in Form 3J, and both 3I and 3J has been again submitted to State Drug Controller, and then again the State Drug Controller issue order purchase copy, and this is the cycle that we have to follow for the procurement and record keeping of opioids. Now I'm briefly discussing about the old rule before 2014 amendment and after 2014 what changes has been done. Before 2014 there is not any specific definition for any medical institute. They just mention the medical institute. After 2014 amendment, all institute become recognized medical institute for procurement and stocking of essential narcotic drugs. Before 2014, the practitioners or medical specialists who want to procure opioids are defined as approved practitioner, while after 2014, all practitioners are who wants to procure are become registered medical practitioner. And the list of drugs has not been properly defined before 2014. They mentioned that medicinal opium, opium alkaloids derivative, and pethidine. They only mentioned the morphine, and all other drugs has not been mentioned. They are under opium alkaloid derivatives. So there is lacuna in the number of medications and quantity of medication that to be stored. And after 2014, a specific definition has been keyed, that is essential narcotics drugs, and the list has also been came, and the quantity is also mentioned in this 2014 amendment. These are the different forms that I have already been discussed. And after this amendment, there is specific form, and all form are single and simple. Before 2014, there is very complex forms, and all steps requires some financial burden to the institute, and institute or medical practitioner has to apply in some kind of stamp paper, although its amount is minimum 5 rupees or 15 rupees, but the institute has to gone through these steps for authorization. Now there is a form 3B. Previously it was DD8. For consignment note, this is the main changes. There is only one form 3C. Before 2014 amendment, there is multiple forms DD2, DD3, and DD4, and these all forms are very complex. For morphine, one has to take DD2. For fentanyl, they have to take DD4. This is a very complex steps, and all this form has been signed by the different excise officer or different transport officer. It is very cumbersome. And similarly, for patient level dispensing of opioids, there is simple form 3E, and previously it was DD12 form, and this DD12 form is still being in used. And if you are using DD12 form, we have to fill the 3 copies of 12 form, and this stands to licensed chemist for dispensing of opioids. There is no form or any kind of pro forma given by older rule for the next year's procurement. Like in after 2014 amendment, the form 3J is there for the next year's procurement. And in older rule, they have to apply again with form DD5 and then again repeat all the steps. Although the validity of DD5 is for 3 years. Now, I'm covering this, small steps for the future changes that can be done by in future years. That there is one suggestion given by the Addictions Psychiatry Society of India. In this suggestion, they suggested that the law enforcement sector spent inordinate amount of time and resources for punishing drug users. And the NDPS Act is aimed to ensuring the availability of narcotic drugs and psychotropic substance for medical and scientific use. But still the medications are remain inadequately accessible. And the healthcare sectors remain at risk of harassment at the end of law. And the rules under the NDPS Act for the treatment facilities of drug dependents need to be consistent with the Mental Health Care Act, which came in 2017. There is one high-level meeting has been done in 10th November 2021 in the PMO with the following officers: Department of Revenue, Ministry of Home Affairs, Narcotics Control Bureau, Social Justice Ministry, and Health Ministry. And this officers has proposed and recommended on decriminalization critical steps, removal of word addict, and possess shall be replaced by possesses more than small quantities, and mandatory treatment for de-addiction. Similarly, future prospects are like Aadhaar-based registration of patients. So there will be uniformity in all over India. The digital healthcare or mHealth-based record keeping of patient and data can be transferred between the centers. And now the ABHA ID has been came, which is the Ayushman Bharat Health Account. It is a 14-digit number that will uniquely identify the patient, and all the patient related data can be stored in this account, and as and when required, patient can share with their treating physician. And even cancer registration system can be used for patients who are in advanced disease. Now coming to the our institute level, what we are doing for the procurement, stocking, and dispensing. This is our double locking system where all opioids has been kept, and this is our own hospital-based intranet system, which are developed by our department. In this system, we are incorporated our two centers, that is ISCH AIMS and National Cancer Institute Jhajjar, into the same platform. And this is the digital record keeping of patient, in which we entered all details of patient. And when patient is free to visit any of our two centers, NCI or ISCH, for procurement for their treatment, and can get medication from any of these two centers. And we have a real-time data, so patient visit can be monitored in this system. And this is our resident who are entering in the system. And this is a Form 3E generated by online system. And the details of patient and the quantity of medication has been entered with the name of resident or faculty who are prescribing the medication, and also the registration number and stamp of resident. That's all. Thank you all.
Thank you, Brajesh. So, are there any question in the chat box? Let me see. So Dr. Preeti wants to know what is the present status of Form DD12 at the level of individual pain clinics in Delhi? What all records should be kept in and how long? Would you like to answer, Brajesh?
Yes, still the institute are using DD12. Even private practitioners are also using DD12. And in 2014 amendment, it not been mentioned that DD12 form is not valid. So we can still use DD12 form, and all form records should be kept for 2 years from last entry.
Dr. Nagesh wants to add a couple of points. Dr. Nagesh, please go ahead. There are a few more questions. We will take it afterwards.
Okay.
Dr. Nagesh,
yeah, I got unmuted. Thank you. First of all, congratulations. Excellent lecture on a very complicated subject. I was involved very, very closely in the amendment of the NDPS Act because I happened to be the IAPC president at that time. A couple of things which I think everybody needs to understand. Number one, when you talked about RMI, all government institutions are deemed as RMI. They don't need to apply for RMI status, but they need to follow all the other rules, the training of the doctor, so on and so forth. So that is important. The second thing is that there is absolute major confusion about involvement of the revenue department. Now, IAPC, Archana and her team did a survey, and there are a fairly large number of states where the revenue department still tries to poke its nose. But be very clear, everybody, that revenue department has absolutely no role to play in respect of the essential narcotic drugs. They have no right to come. They have nothing that they can say. The other important thing is that there is no such thing as a quota system. Earlier, the drug controller or whoever it was used to say, okay, you can do this. If you are using a certain amount of morphine that you have ordered or any of the essential narcotic drugs, and say in between, before the next cycle, you run short of it, you do not need permission from the drug controller. You can go ahead, you can order. The only thing that you need to do is inform the drug controller, probably increase the expected need for next year, and you need to maintain records about who are the extra people to whom you have given the narcotics. That is very, very important. Okay. But there is massive confusion all over the country about the involvement of revenue department. Even in Karnataka, in spite of my breaking my head with the drug controller, still things have not really moved. So it's a very, very frustrating sort of situation. But overall, I must congratulate you. You've done an excellent job. The only thing is that let not the PG students get confused about the old and the new, right? You gave it a wonderful historical thing, but that history should be immediately forgotten. And they should think about the new things. And what you mentioned about the recent meeting in November, of course, 2021, we hope that they will take it forward. And I'm sure, I think even Sushma was wanting to try and get the Drug Controller General to call the state drug controllers for a meeting. I think that, things have not moved as much as we wanted, but I'm sure Sushma will be able to do that. So that's all that I've got to say. Thank you.
Dr. Nagesh, I think very, very important points you have highlighted. This is very important to understand everyone that this is our responsibility. I think government has done their job, but in your own states, you have to go to and meet all these people, those who are interrupting in implementation of this rule. And it will be a big task initially, but once you will do streamline the process in your own states, I think the things will move very, very, very smoothly. So for example, in Delhi, when it was a difficult task to streamline this thing, but in Delhi now it is absolutely streamlined. Anybody who wants to procure opioids, they can procure opioids. Anybody, absolutely the center, we are we are following the central rule as absolutely well. So this is our responsibility also. So we have a lot of responsibilities actually. Responsibility to streamline this rule wherever, in whichever state it is not happening. Responsibilities to train your juniors, those who are on your team, so that they should prescribe safely. Responsibility to teach and train your pharmacists, because even the pharmacists, I have seen that a lot of pharmacists, they don't know about the dealing of opioids. And then responsibilities of about this keeping it safely. Actually, we should not be worried about so much. We should not have phobia, but definitely we should be very meticulous in keeping the record. Uh, and I have seen in ICU and in other wards, we are keeping the records of all other medications. Only thing, because there are so many myths and misconceptions attached with opioids, there are so much of phobia about opioids. We have to keep it very carefully. And obviously this is for sure that it should not be misused like like a lot of other medications are also misused, but opioids can be misused badly. So it is our responsibility that it should not be misused, overused, or abused, or diverted for any to anyone other than patient. So we have responsibilities. So in new year, I am giving you a lot of responsibilities. So what I suggest that the states where this is not implemented, one person should take the lead. IAPC can help you. We are trying at our level best wherever this our program is going on, wherever people are planning to start dedicated palliative medicine program. We, from the beginning, we are trying to help them that they should have a streamlined and very seamless procedure. Actually, there is hardly any problem. Only thing, initially everything will have a problem. So initially there will be a problem, but a problem in the sense you will have to run around, you have to break your head to so many officials, and finally once it is streamlined, I think you will be able to make it definitely. I just want to allow one thing which is very important, that recently, I have received a message that this whole narcotic department is going to Home Ministry, and one official called me and asked me my comments that whether we can use any other alternative substance in Ayush, other than for the opioids like morphine, pethidine, morphine, fentanyl. I said no, this is not. So so I have given my comments. Don't worry about that. But this is again our responsibility. Now again, this is our responsibility that all the palliative care physicians, those who are practicing palliative care wherever they are practicing, because you are the one who are using opioids maximum for your patients, and you have to use it very judiciously. You have to make sure that the patient who needs morphine is getting morphine, and those who don't need morphine, and we can use alternative, because IASP, International Association of Study of Pain, also has given a position statement on judicious use of opioids, and they clearly said that it should be used in a very selective circumstances in advanced or terminally ill cancer patients. They have used it cancer patients, and we should try to use on these patients as well as other chronic pain patients. We should try to use other non-pharmacological management methods. So again, this is again our responsibility, that we should try to use as much as possible, because I myself have seen that if we use it, we assess our pain judiciously, and if we will try to use other, because in certain group of patients, in neuropathic pain patients and another patient, if you keep using opioids and keep giving opioids, in frustration, it may get diverted to the family members rather than giving pain relief to the patient. So we have to be a good pain physician. We have to be a good palliative care physician. We have to be a responsible citizen as well as palliative care physician of the country, so that based on this lecture, based on the comments from Dr. Nagesh, and based on your own understanding, you will use opioids only for those patients, those are eligible for it, those can be benefited by it. If patient is not getting benefited, try to use other modalities and try to assess your pain again carefully, that why this medicine is not affecting me, there is something else I can do for this patient. So a lot of responsibilities New Year's. So again, if there are any other questions. Double locker should also be maintained in OPD or at the in-house pharmacy. Everywhere, I think, Ravi, this double locker system again is basically a system which will, we want that opioid should be used safely. So I think double locker should be used in OPD also. It is not in the pharmacy. If it will be unlocked or if it be not locked properly, I think it. Presently, in the absence of common registry, it is not possible for patient to receive morphine from 2 different centers. How can we prevent it? Dr. Geeta, what exactly you want to ask? Okay, so you don't have common registry in your 2 hospitals. You have 2 different centers. So you have to use your, what you want to say?
No, ma'am. I found when we went for home care, the patient is is having contact with 2 different palliative centers, and 2 palliative centers are visiting the same patient.
Oh, getting morphine.
Yes, yes.
So see this, Dr. Geeta, it is responsibility of home care team that how many we can't prevent if, because now in Delhi there are 3-4 places where palliative medicine is practiced. They must be getting morphine from this center and that center. So this is our responsibility also when he is coming to us, that whether he's going for this consultation, whether he's procuring opioids from any other hospital. And this is also responsibility wherever, it's our combined responsibility. If you're going at home care, you must definitely visit this and you must have a word to this, that this word of caution to these patients, that this should not be, there should not be any misuse or overuse, or collection of the medication should not be there. Okay.
Yes.
Here,
Yes,
Dr. Geeta.
Yes, ma'am.
So, next question is, first time in-house morphine procurement. Can you please guide me for the steps, although covered in PPT? Any such measures to be taken? So, Ravi, I think you can talk to Dr. Brajesh directly. Archana will send you the number. You can talk to Dr. Brajesh directly, okay? Because he has explained it well in detail. But still you won't have any confusion, you can talk to Dr. Brajesh. Dr. Karthik, is it possible to increase the opioid allotment during middle of the year? Yes, Abhi, Dr. Nagesh has said same thing, that all hospitals are RMI, and where the Karthik is working is a big hospital. It is deemed RMI, automatically in RMI. If you have exhausted your quota, you can buy medication. Just you have to inform drug controller in a certain prescribed form, which Brajesh has told. So in that form, you have to inform them that we need these many medication extra for the patient. Clear, Karthik? What training is required? So Dr. Kale is asking what training is required. So basically, Dr. Kale, actually this is this will not be the right thing that I will say this training is good or that training is good. From Medical Council of India, I have confirmed this with the National Medical Council. From Medical Council of India and National Medical Council, they say that people should know how to prescribe opioids. So definitely there are good trainings available all over country. I don't know, it's like I won't be able to give you all the great details, but definitely MD palliative medicine, people those who are doing diploma from Cardiff University, people those who are doing fellowships in various hospitals, I think they know how to use it. But again, I will say that now there are a lot of MDs are there in the country. They should learn safe practice, and they should go and get themselves appointed in various hospitals wherever it is getting practiced. So I think we will have a robust system all over. But training, and IAPC obviously is having a course in twice in a year. That course also means basically person should be trained. I don't know whether if a person has done MD and he has not learned safe use of opioids, This is again your responsibility that we must learn all this in various trainings. Is it clear, Dr. Kale? Yeah.
Sushma, if I might just add regarding the training, you see, this has been discussed very often as to how many days training, some, because I was talking to people at the Ministry of Health, 3 days, 10 days, whatever. Now it's basically left to the state, right? Now, for example, an IAPC course with Part B, 10 days, absolutely fine. Because wherever you go, they teach you how to use. Now, we have been training a large number of doctors, not only from Karnataka, but from Odisha, because we are setting up, a 110-bed thing, which will be inaugurated probably in June this year. The Odisha government, recognizes the training that we have given. So there is nothing specified in the law. It is left to each state. But anyone who does the Part B of IPC course is good enough.
So I think clear. There is one more hand is raised. Who wants to speak? I don't know. Can you see? Any other question? First, let me finish the questions. Should Fortpin also be kept in the double lock and key? No. Fortpin is not included in this, and not in these days nobody is using Fortpin, Dr. Preeti. Can we have a bureaucracy level sensitization at annual IAPC conference? Just a suggestion. We can think of it. Maybe not in this conference, but definitely next. We will call all the bureaucrats in this conference, next conference. Is it possible to order extra? I have already answered. Morphine and salts are all preparation containing more than 0.2% of morphine. These are words in the act. So injectable morphine is also, yes, injectable morphine is also included. Then Dr. Brajesh, Archana, please connect Dr. Ravi and Dr. Brajesh, okay? Okay, so all the questions are over, and there is one more hand raised. Whose hand is raised? Archana, can you see? I can't see.
No, ma'am.
Okay, then. So if there are no more questions, this is a topic which gives a lot of doubts in our mind. But once you will start practicing, once you will become a responsible palliative care physician and responsible citizen of this country, automatically you will start using safe practice or judicious use of opioids. Practice will come in your nerves, in your brain, in your heart, and it will not be a problem. So again, 3 responsibilities that all the palliative care physicians in different states, they will work hard to streamline the process. Second, all the palliative care physicians, those who are practicing, they will use it judiciously, and they will make sure that record keeping, storage, and everything is proper. And third thing, they will also make sure that the juniors, those who are practicing in the setup, they are adequately trained. Thank you very much. So we'll see you next week, Monday morning. Thank you, Dr. Nagesh, for giving your comments, and Brajesh for such an informative lecture. And thank you everyone for joining. Thank you, Nisha, and thank you, Archana. And once again, Happy New Year. I hope that this new year brings a lot of new avenues in IAPC, lot of new research findings in palliative care practice all over country. And we will work hard to make sure that our country will become, all the patients, those who need palliative care, will not be deprived of palliative care.
Please ask everybody to register for the conference.
Yes, doctor. Yeah. I'm giving this information in all the platforms, and this platform is also
requesting all the people here to. It's a little different conference track-wise thing, and we are trying to have a slightly different conference. So please do come to Bangalore.
Yes,
Those
yes.
who have not registered.
Register soon, please. Okay. And there are a lot of bursaries available. Thank you very much. Thank you. Thank you, Dr. Nagesh. Thank you, Archana, Nisha, Brajesh. Thanks a lot. Thank you, everyone.